Thank you, Dr. Ali, and for the presentation. And I want to thank Efri and Dr. Medhat Aimer for giving me the opportunity to present here among the colleagues. And I want to thank Dr. Haytham for carrying the heavy burden of discussing the initial part of the DNA fragmentation regarding its correlation with the male infertility, indications, and the methods of testing. Now I'll go to the next step, which is the management of these cases. Again, we'll be referring to our two papers that we are presenting today. These are two clinical guidelines based on systematic reviews for published data regarding sperm DNA fragmentation. The first one is done by Dr. Sandro Estevez, and the second one by Dr. Agarwal. Both groups are from different countries, including different scientists from all over the world who shared in these clinical guidelines. So what are the treatment strategies that are available for treating high sperm DNA fragmentation? Let's begin with a simple thing. First, the lifestyle changes. We should change, or we should avoid any risk factor that will lead to increased oxidative stress. Increased oxidative stress will subsequently lead to increased sperm DNA fragmentation. These risk factors, as Dr. Haytham has elaborated, including avoid hyperthermia, for example, saunas, hot tubs, steam rooms, some occupational exposure like truck drivers, outdoor workers, especially in hot countries like, for example, in the Gulf where we are now. We should tell the patient to stop smoking, to quit smoking, advise him to reduce his weight, and to avoid occupational hazards if possible. Some occupational hazards like those working in factories, for plastic factories, fertilizer factories, they are exposed to high levels of oxidants. So if they are affected, if they have infertility, they can, if they can change their occupation, or they can use higher levels of protection in their work. Dr. Agarwal has mentioned here, or has published 4 of the studies that were discussing the lifestyle modification, including those for obesity and smoking. The next simple one is the frequent ejaculation. It was found that frequent ejaculation or daily ejaculation may lead to reduction of DNA fragmentation by 25% in up to 90% of patients with high DNA fragmentation. So this is a simple, cheap method, risk-free, that can be used as a methodology to decrease DNA fragmentation. And again, Dr. Agarwal has published the 6 studies discussing this topic, and all 6 studies found a significant reduction of DNA fragmentation with frequent ejaculation. How does this frequent ejaculation work? It simply decreases the epididymal transit. So it will decrease the exposure of the sperm to oxidants during the epididymal journey, and will decrease the sperm DNA fragmentation. So when we are talking about oxidative stress, then the next step will be the antioxidants. And as usual, antioxidants usually raises conflicts, and the studies didn't differ much. There are a big conflict regarding the efficacy of antioxidants in high DNA fragmentation. Although the majority of the studies said that it is beneficial, some said that it has no effect, and few studies went to the next level, said that prolonged use of antioxidant may even harm the sperm by causing reductive stress and increasing the DNA fragmentation. However, most studies used short-term therapy for 3 to 6 months, and the most common antioxidants used were vitamin C, E, L-carnitine, folic acid, zinc, selenium, and coenzyme Q10. Usually in our group in Hamad Hospital, when we find conflict in the result and we find confusion, we tend to do our own research to try to find out which is nearer to the to be implemented. So we did this study on 148 patients. 119 were having idiopathic infertility and 29 unexplained infertility. They were given short course, 3 months, of a super antioxidant, which is called Fairhaven Pro. It contained all the antioxidants that are seen here in the picture, with the optimum concentrations for these antioxidants. At the end of the study, we found that there was significant reduction in sperm DNA fragmentation following treatment in patients with idiopathic infertility, And the same happened in patients with unexplained infertility with significant reduction of sperm DNA fragmentation. Actually, there was significant improvement in most of the serum parameters, especially if you see here in patients with idiopathic infertility, regarding sperm concentration, motility, progressive motility, normal morphology. All of them showed significant improvement. Now, the next oral treatment will be treatment of genital infection. It was found that in 10 to 20% of infertile men with urinary tract infection, STDs, and prostatitis, they have increased sperm DNA fragmentation. However, in these patients, the culture is basically negative in around 80% of these patients. But we tend to treat these patients hoping to decrease the infection and hoping to decrease sperm DNA fragmentation by giving them antibiotics coupled with antioxidants to help them in achieving less DNA fragmentation and better fertility. This was discussed only in one study. Regarding varicocele repair, there are tens of studies that were discussed by both Dr. Agarwal and Dr. Estevez. Most of the studies have proven that with varicocele repair, there is reduction of sperm DNA fragmentation in the period from 3 to 12 months following surgery. I chose this meta-analysis of 7 studies. It was a very nicely done meta-analysis, and they indicated that sperm DNA fragmentation decreased after repair with a mean difference of 3.4%. What about the grade of varicocele? Should we do varicocele for high DNA fragmentation in all grades? Nye et al. Said that it's only favorable in high grades, which are grades 2 and 3. However, Krishna Reddy et al. Said that no, it was beneficial in all grades, and the benefit was similar in low-grade varicocele as high-grade varicocele patients. Avoid iatrogenic damage. Actually, this point is not discussed by the 2 papers that we are discussing today, but I found it's very important to elaborate on them here. One of the important causes of high DNA fragmentation is us, the clinicians and the laboratory technicians and embryologists. All the handling of the samples during DNA testing or during IVF may lead to increased sperm DNA fragmentation even in a normal sample. So we should avoid long abstinence. As in our lab, we advise patients for only 1 day of abstinence before sperm DNA fragmentation testing. We should avoid long incubation. When you receive the sample from the patient, don't leave it for a long time in the incubator, because this will increase the sperm DNA fragmentation. Proper media selection during IVF, because some of the medias may increase, or actually some of the medias may help to decrease the sperm DNA fragmentation even with normal samples. So we must be cautious when selecting these media. Proper handling. Excessive mixing and excessive needling of the sample, excessive exposure of the sample to different temperatures, like putting it in the incubator, out of the incubator, all this will lead to increased sperm DNA fragmentation in the sample. The processing time, should be as short as possible to avoid the fragmentation, especially in those patients going for ART using cryopreserved sperm. We should not thaw them for a long period before the ART. We should shorten the period between thawing and the ART being done. Now, the next treatment modality for patients with high DNA fragmentation is ICSI. But here we'll face the dilemma. Is using ICSI during, what is the sperm source? Shall we use testicular sperm, or shall we use ejaculated sperm with using sperm selection techniques like PICSI, IMSI, and MAX? I will discuss this in details now. For those who are advocating for using testicular sperm in patients with high sperm DNA fragmentation, their hypothesis is that testicular sperm exhibit more intact chromatin and less sperm DNA fragmentation than ejaculated sperm, and that sperm DNA fragmentation mainly occur during epididymal maturation and transit. Let's find the studies that prove this hypothesis. The first one was 2005 by Greco et al. He used tunnel assay. He found that DNA fragmentation was 5 times higher in ejaculated sperm than testicular samples. Moscovich in 2010 found a 3-fold increase in ejaculated sperm, DNA fragmentation in ejaculated sperm than testicular sperm, also using tunnel. Then Mehta et al. In 2015, again using tunnel assay, found a significant increase in sperm DNA fragmentation in ejaculated sperm compared to testicular sperm. In the same year, SDF, using spermatochromatin dispersion test, found the same finding, which is the ejaculated sperm has significantly higher sperm DNA fragmentation than testicular sperm. Steele et al. Had proved the hypothesis of the benefit for testicular sperm in a different way. He got patients with obstructive azoospermia and compared epididymal sperms with testicular sperm. He found that the epididymal sperm has significantly higher sperm DNA fragmentation than testicular sperm, which proved that the epididymal transit, or that the DNA fragmentation occurs during the epididymal transit. Suganuma et al. Did an animal study and have very interesting finding. He found that animals with abnormal spermatogenesis, when the sperm passed through the epididymis, the DNA integrity is affected and there is high DNA fragmentation. While those with normal spermatogenesis, the passage through the epididymis didn't affect the integrity and the DNA fragmentation was maintained. So he proposed here that DNA fragmentation is a result of both abnormal spermatogenesis and the epididymal transit. So the sperm is susceptible, and when exposed through the epididymis, then the susceptible sperm will defragment. However, the normal sperm may have more capabilities to be intact. Now, what about the outcome of using testicular sperm in ICSI? The first study, again, was by Greco et al. On 18 couples with at least 2 unsuccessful ICSI with a high DNA fragmentation. All the cycles, next cycles were done using testicular sperm. He found that there was significant improvement in implantation rate and pregnancy rate when using testicular sperm compared to the ejaculated sperm. 10 years later, Mehta et al. In 24 couples, again with 1 or more unsuccessful IVF or ICSI, with high DNA fragmentation using tunnel assay, he used testicular sperm for all their next cycles, and he could achieve pregnancy, clinical pregnancy, in 50% of these patients using testicular sperm. In the same year, Dr. Estevez has published the first big series of patients using testicular sperm for high DNA fragmentation. It was 172 couples with high DNA fragmentation by spermatochromatin dispersion. 81 did ICSI with testicular sperm, and 91 did ICSI using ejaculated sperm. He found that the live birth rate was significantly higher when using testicular sperm, and the miscarriage rate was significantly lower when using testicular sperm than ejaculated sperm, of course. Then Bradley in 2016 did a very nice study on 2,700 ICSI cycles. The DNA fragmentation was tested in these cycles by assay similar to SCSA with a cutoff value of 29. 448 cycles were with patients who are having high sperm DNA fragmentation. The next cycle, 80 patients opted to go for no sperm selection, a regular ICSI protocol, while 368 used intervention for sperm selection, whether using testicular sperm or sperm selection techniques like PICSI and IMSI. He found that when using testicular sperm, the biochemical pregnancy, the implantation rate, and the live birth rate was significantly higher than when using other methods of selection, and compared to the control who didn't use, who used only ejaculated sperm without any intervention. This was the same when tested for all blastocyst transfer or when single blastocyst transfer was done. Next year, 2017, this is another study on 71 couples with high DNA fragmentation using tunnel assay. 31 went with testicular sperm, 40 went with ejaculated sperm. And again, the clinical pregnancy and the ongoing pregnancy rate was significantly higher when using testicular sperm. Similar to the antioxidant study, when we find conflict, we do our own study, and this study was done in 2018 in our center in Doha, in Qatar, on 36 couples with high DNA fragmentation, and they have previous ICSI using ejaculated sperm with normal female factor, of course. All next cycles were done using testicular sperm. We found that the clinical pregnancy was significantly higher, nearly tripled when using testicular sperm versus ejaculated sperm. The the pregnancy loss was significantly less with testicular sperm, and the live birth rate was significantly higher when using testicular sperm. However, we should not say that testicular sperm is the ultimate goal using it in ICSI in patients with high DNA fragmentation, because it has a lot of cons. The evidence is still limited. As you see, it's only a handful of studies that I presented to you now. The cohort is relatively small, and there is lack of proper control in all the studies, including our study. We have to put in mind that the sperm DNA fragmentation can occur intratesticular. So when using testicular sperm, we are still having the risk of still using a sperm with high DNA fragmentation. Although surgical sperm retrieval in these cases is done by simple testicular sperm aspiration, however, surgical complications are still there, including postoperative pain and hematoma. We have seen that, as Dr. Haytham said, there is no consensus on the testing method used. There is no standardization of the cutoff value, even for the same test. It has different cutoff values. And you have to put in mind that any study, there are other co-founders for ICSI outcome. One important thing to think about is the aneuploidy, which is proving to be higher in testicular sperm than ejaculated sperm. So we have to counsel the patient regarding all these things and not directly go to testicular sperm. For those who advocated for using ejaculated sperm in patients with high DNA fragmentation, they say that high DNA fragmentation does not affect ICSI outcome, and that the new selection methods are very helpful in selection of intact sperm. This study by Wang et al. On 381 couples using sperm chromatin dispersion with high DNA fragmentation. They did ICSI using ejaculated sperm without any intervention, and they did FAT cycles for these patients. They found that with IVF, progressive motility was significantly higher in patients with low SDF and fertilization rate, but this was not true except for the progressive motility for ICSI. But there was no difference in the pregnancy rate, miscarriage rate, and the live birth rate between low DNA fragmentation and high DNA fragmentation. Another study on 390 couples that did 1,216 cycles with a normal female and high DNA, different levels of DNA fragmentation using ejaculated sperm without intervention. They found no difference between all the DNA fragmentation ranges, ranging from less than 15 to more than 30, regarding implantation rate, recurrent pregnancy rate, pregnancy rate and pregnancy loss and live birth rate. What about the selection techniques, sperm selection techniques? I will present here two very nice studies. The first one, it was a randomized controlled trial on 396 patients, comparing two methods of sperm selection. 200 patients went with physiological intracytoplasmic sperm injection, the PIXI, and 196 used the magnetic activated cell sorting, which is the MAX, in a normal female factor in patients with high DNA fragmentation measured by tunnel. Here, when they presented the results, we can find that the clinical pregnancy is high as normal, and there is no significant difference when using the two methods. So the methods resulted in a normal pregnancy rate. This is number one. And either method, if you have it, you can use it. You don't have to labor yourself by getting new methods. You can use anything that you have to select sperm between the PIXI and the MAX. The other one is having a study design, same like Bradley, who used different interventions for sperm selection. It's also an RCT on 320 couples with different methods of intervention, either the gradient, different gradient concentration, PIXI, MAX, or using testicular sperm, normal female, and with patients with high sperm DNA fragmentation, cutoff value more than 20.3. They find that with PIXI and MAX, there was significantly improved clinical pregnancy, or higher clinical pregnancy than testicular sperm. With PIXI, the implantation rate was better than MAX and testicular sperm, and the ongoing pregnancy rate was higher, significantly higher with PIXI and MAX than testicular sperm. So what does our two clinical guidelines that we are discussing today say? Regarding the antioxidant use, recurrent ejaculation, and control of inflammation, Dr. Agarwal group recommended using these methods by grade of recommendation of C. It's worth mentioning that these grades of recommendation are based on Oxford Center for Evidence-Based Medicine. So it is evidence-based recommendations. STBs didn't comment on these three methods. Lifestyle modification, agreement between both guidelines with a grade of recommendation of C. Varicocectomy was recommended by Agarwal group with a grade of recommendation B to C. It was discussed by SDF with no recommendation. Using ICSI if persistently high, meaning persistently it is resistant to treatment, with a recommendation of B to C between both groups. Using alternative method of sperm selection, like, as we said, PICSI and MC and MAX, it was recommended by Agarwal with a grade of recommendation B to C, but not recommended by Dr. Estevez. Using testicular sperm for failed, after failed ICSI, so this should be put in mind. It should not be for the first ICSI, it should be after failed ICSI or failed ART. It's recommended by both groups with a grade of recommendation ranging between B to C. So what about the international guidelines? What did they say about the DNA fragmentation management? Regarding the use of antioxidant, the European Association of Urology said that there is no clear recommendation of using antioxidant in patients with idiopathic infertility, although antioxidant may lead to improvement of semen parameters. So they say that there is improvement, but they don't recommend it yet. Similarly, ASRM and AUA said that there are no clear guidelines, and we should counsel the patient that there are no clear or benefit on their benefit in treatment of male infertility. Regarding varicocele repair, the European Association of Urology, with a weak recommendation, considered doing varicocelectomy in patients with high DNA fragmentation with otherwise unexplained infertility. Now, what about ICSI and the sperm selection, testicular sperm? All the societies didn't mention anything about them, either recommendation or even discussion. So I would like to say that we are not advocating for DNA fragmentation, but we say that if our patients have a possibility of being treated of their infertility, if our patient have a chance to increasing their fertility status, if having a chance of going to natural pregnancy instead of going for assisted pregnancy, having a chance of increasing their ART results, we should investigate and try these methods, and we should not just deny them of using them. Thank you very much.